Okay. I was delighted to be asked to talk at this event on the topic of acceptance and commitment therapy for depression. And really, acceptance and commitment therapy is a form of cognitive behavioral therapy that combines mindfulness and behavioral psychology to try and promote effective living across a really wide range of different conditions. And so that's why the subtitle of this talk is as it is. What I'm going to talk about is a little bit of some of the historical and conceptual roots of ACT, or acceptance and commitment therapy, a quick overview of the model, some discussion about how ACT approaches mindfulness, some brief ideas about how we apply ACT to depression, and then finishing off with some slightly more theoretical or conceptual ideas about aspects of the relationship between ACT and other kinds of modern psychological therapies. So the first little bit is a kind of a walk through some history, and if we go right back to when behaviorism began to be seen as being an approach to psychological therapies, really back in the 1930s and 40s, behaviorism was seen as a kind of rejection of the psychology that had happened before that. The psychology before that had been mainly based on psychodynamic, psychoanalytic concerns, and it was the behaviorists of the time didn't feel this was a good grounding to create a scientific study of psychology. And so they wanted to develop things that were more overtly measurable and falsifiable from a traditional scientific perspective. But what's often not realized is that there was not one voice within behaviorism during that time, and that there was different flavors of behaviorism. So for example, the typical things that we think about behaviorists now are that they reject the idea that we can even consider thoughts and feelings and internal motivations as being objects of scientific study. And that certainly was the position that came to be known as methodological behaviorism, and it is the flavor of behaviorism that came to dominate most of behaviorism. But one particular individual who you may have heard of, B.F. Skinner, a much maligned person, had a different view of behaviorism. He was famously quoted as in a symposium in 1945, intellectually sparring with a methodological behaviorist of the time called Edwin Boring. And Skinner said, if we develop a psychology that only focuses on overt behaviors and neglects the inner world, it'll be a poor kind of psychology. And so I am interested in the boring from within, is what he said. So this was his idea that radical behaviorism. What is really radical about radical behaviorism is that everything an organism does is behavior. So even as we're thinking, as we're feeling, that is behavior. And what he wanted to try and do was to, with the same kind of precision with which they were studying overt behaviors in terms of stimuluses and responses in animals, in laboratory situations, and thereby crafting out experimentally a very scientific and detailed analysis of what is it that controls and influences behavior. The grand scheme for Skinner was to bring the same kind of precision to the inner world. How is it that thoughts and feelings influence and lead to behavior? But of course, one person, one lifetime, he only got so far, and it was felt that really the answers that he had to that problem were not adequate, not useful, and so forth. But when we think about the legacy that he had for therapists, of methodological behaviorists, sorry, behavior therapists of the time really felt very straitjacketed. You know, that there's this dogmatic approach, we're not allowed to talk about thoughts, feelings, that's a non-scientific piece of study. And so then when we see in the 1970s a much more of a kind of coming out of that ideology of the 60s and 70s, a blending of some of the sensibilities of humanism and Buddhism with people who were, you know, calling themselves behavior analysts, we start to see some of the groundwork for the later emergence of things like acceptance and commitment therapy, dialectical behavior therapy, and these more modern approaches to behaviorism. So When we think about ACT, it's a model, it's a kind of scientific model that tries to answer this question of what is it that's influencing behavior in this moment. It's not a mind model, and for that reason it sometimes is hard, particularly for therapists, to get to grips with the ACT model, because they're used to seeing therapy models in which the mind is somehow represented. There's somehow kind of a representation of how the mind might work. In ACT, we don't have that. Instead, we have a model of 6 interdependent and overlapping behavioral processes that seek to answer, in this moment, what is it that's influencing behavior. And we have that model for a very particular reason, so that we can both understand what is it that's influencing behavior, but also that we can influence and shape and help people to change their behavior in ways that they would want to change. So some of the definitional statements are that ACT is a therapy approach that uses acceptance and mindfulness processes and commitment and behavior change processes to produce greater psychological flexibility. So the name of the game in ACT is producing psychological flexibility. Some features of that are that it's not an eliminative model. It's not about getting rid of a state that we don't like, or reducing something that is unpleasant or unwanted. It's about producing greater psychological flexibility. And psychological flexibility is defined as the ability to contact the present moment more fully as a conscious human being, here now. But not just to do so as an end in itself, but to do so because it allows us greater choice and flexibility over our behavior. So particularly that if our behavior is something that is not leading us to live effectively, that is not leading us to live towards things that we would care about, then being more present, mindful and accepting will allow us greater capacity to change that behavior. Conversely, if our behavior is leading us towards things that are valued, valuable, things that we would choose to be about in life, then greater psychological flexibility will help us to persist in doing that behavior even when there are obstacles present. And the ACT model itself can be represented as a hexagon. It's sometimes kind of quite cutely termed the hexaflex because it's a hexagon model and it's about flexibility. And there's 2 sides to this. So the first side is kind of an inflexibility side. If these 6 processes are occurring, then a person is going to be less flexible, more inflexible. So the first of these is experiential avoidance. And again, as I describe these, they're not things that are neatly defined. They're overlapping, interdependent. So the first one is experiential avoidance, things that we do to try and not have the experiences that happen inside ourselves. So this can be little things like distracting ourselves, trying not to think about, or it can be bigger things like drinking, substance use, all sorts of things like that. Not talking about some of the things that Stephen talked about, not talking about how we feel might be an example of experiential avoidance, avoiding our own internal experiences. The next one is cognitive fusion. So basically how we stand towards our own thoughts. Do we see our thoughts, as mental events? Even the ones that are really hard or unpleasant, are they seen as mental events, experienced as mental events, or are we really sort of locked into them, trapped inside them, entangled within them, treating them literally? In a state of cognitive fusion, that's what we'd say was happening in terms of how we stand towards our thoughts. The dominance of the past and future. So to what degree are we here, now, versus off in our heads somewhere, trying to solve the problem that's coming up next, or what if this happens, or what if that happens, or equally somewhere in the past, ruminating, why did this happen, or you know, thinking about some previous event that isn't in the here and now, being dominated by memories and so forth. Attachment to the story that we have about ourselves. That as we kind of go through our lives, we build up kind of reasons, explanations, stories about why things happened, about the kind of person that I am. And if we get very drawn into and attached to this story, that story itself can come to dominate and can come to make us less flexible. It's very typically a scenario when working in psychological therapy with somebody where someone has perhaps a story that is no longer self-serving, that doesn't help the person any longer. And yet when you try to explore this with them, very often the experience is that it's defended. The story is something that's maintained and preserved and defended, and explorations of the story can be experienced as being unwelcome. So when we are very attached to our story about who we are and what's possible for us, again we have less a flexible approach to living. A lack of clarity or contact with values. So things that, so basically not really knowing what it is that I care about, not being in touch with things that matter to me and what I would make my life stand for given a choice. And very often we need to think about, when we're thinking about the most vulnerable people in our society and people who often come for psychological therapies, we need to think about this in terms of the context in which people have lived. That how often have they been asked, what is it that you care about? What is it that matters to you? If you got to choose, what would your life be for? And it's just not something that people have spent time doing. So that's a big part of the therapeutic work. And then finally, in terms of action, people not doing things, being inactive. So typically we see this in people that have a depressed mood, not doing things, withdrawing from things, or doing things impulsively, you're trying something but and not being able to persist with it. Or avoidant persistence, doing things with a very kind of persistent quality, but in the service of not experiencing my own thoughts, feelings, memories, and so forth. And then the other side of the model is this kind of more flexible side, the kind of 6 processes that we're trying to instantiate, model, and so forth. So the first is willingness or acceptance. The peculiar thing about acceptance and commitment therapy is this word acceptance often has a double-edged sword. When people hear the word acceptance, sometimes they think that it means resigned, tolerating, given up, or defeated, and that's really not what we mean at all. The Latin origin of the word acceptance is to take in what is offered, as if life was offering you something and you have a choice then to take it in or to not take it in. So we mean it like that, a choice. And the word willingness is one that I would tend to use more often. Willingness has this more kind of active, chosen quality. Are you willing to experience what you're experiencing? The next one is this cognitive diffusion. And we can just do a very, very brief piece to kind of illustrate this. And if you're willing, just see if you would kind of have a go at this. Just put your hands up like this in front of your face and have a look around the room through your fingers. And if you can see what I can see, then pretty much you'll be thinking that if this was how the world looks, it wouldn't be very clear. And what I'd like you to do, and if you look at your actual fingers, you'd see that they too seem very unclear and just kind of hazy. But what I'd like you to do is to kind of push your hands till they're at arm's length, and just notice what happens to your experience of the room as you do that. That the room becomes clearer, you can see better, and that if you look at your hands, you'll be able to see them clearly too. And this is really what we mean about the distinction between fusion and diffusion, that I can look at the world from my thoughts, through my thoughts, in which case these are not thoughts any longer, this is how the world is. Or I can see my thoughts, there's that thought again. That's this experience of diffusion, of stepping back, of creating a little bit of distance between me and the stuff that my mind is giving me. Being in contact with the present moment, literally as it is, simply being here, now, rather than off somewhere in the future, off somewhere in the past. Being able to take a flexible perspective on our stories, so not necessarily being dominated by our stories or seeing our stories as being all-consuming or entangling, but simply being able to see that as a story or an idea about how my life has been or is, rather than it necessarily having to be dominating of our experience. Being in touch with and being clear about what it is that's my personally held, chosen value, what it is that I care about. In a world where I was free to choose, what would I choose to be about? And finally, taking commitment and action towards those things, those values that we really care about. When these 6 processes are going on, we would say the person's more flexible, in a more flexible state. That's the basic ACT model. And when we kind of look at some of the key features of it, in particular in relation to depression, there are some key focuses that emerge from this model. The one is the focus on workability. So what we mean by workability is thinking about the strategies that someone is using to live with their depression and all that comes with their depression, and becoming less focused on the causes of depression and ideas about that, but more interested in how people respond to depression. And conceptualizing these strategies, these responses, as strategies for living. And then asking this question really, sort of, in terms of your experience and the amount of time that you have invested in these strategies between you and me, how effective have they been in living with depression? And we take a very validating and compassionate stance that is very explicit, saying you've done all the things that usually one would do in general. Most of the strategies that people have been using to try and deal with depression are strategies that are focused on an overarching strategy of once I get rid of this, then I will be able to live better. And we kind of ask people, we invite people to have a relationship within which we ask that difficult question about, has that been successful? Has it been effective? And if the answer is yes, there are things I do that help me with my depression, we then help the person search for what are the obstacles for you doing more of that. But if the answer really is that in your own experience, as hard as I have been trying with this strategy, it hasn't really been effective for me living with depression, then let's make our work be about letting go of what doesn't work and finding strategies that will work, that are not about first we get rid of depression and then we live. It really becomes much more about kind of simple, small steps towards values, towards what you care about. And this focus really is about values. The therapeutic work will be about what is it that you most care about. If you were free to choose, we might say things like, imagine, I know that life isn't really like this, but imagine if it really was, that life was like this. You could just, it was like a bowl of sweets, and you could just reach in and say, I'll have that one. I'll have that one. If life was like that, what would you choose? And we make that being the focus of the work. And then based upon that, making specific, concrete steps and actions that are in the directions of those values. And then we use mindfulness, diffusion, and willingness to behave flexibly when these obstacles arise, to try and help people to either change behaviors that don't lead them towards those valued steps, or to persist with behaviors that do lead towards those valued steps. In terms of depression, some of the things that would be key focuses in the work would be, in relation to the symptom of lack of pleasure or low motivation, trying to unhook feelings as reasons for action. So trying to let go of the strategy of once I feel better, or once I feel like doing it, once I feel pleasure, then I will do this. And making values really the reason for action. Pessimism and self-criticism, unhooking thoughts as reasons for action. That we try and instantiate action even in the presence of difficult thoughts, difficult beliefs. And a key feature of depression is this rumination of kind of verbally going over and over causes of depression, implications of depression, and really trying to sort of identify that behavior of rumination as being a strategy, that once I figure it all out, then I will not have depression any longer. And we ask people, in your experience, when you've done that behavior, what happens? Does it lead you to feel freer, more pleasure, more motivation, or actually is it the opposite? So trying to kind of help people guide them to their own experience, where their mind might be telling them this should be working, I should be able to figure this out. And we ask them to let themselves be in touch with their experience of what actually happens when they do these things, and make the work be about which of these are you going to trust, your mind or your direct experience. We try to help people to hold stories about ourselves lightly. We try and help people to make specific commitments to themselves, to others, and we have this freely chosen quality that if you were free to choose, what would you choose those commitments to be? And this idea about values, when someone hasn't been living that and has invested a lot of time and energy in this strategy of beating depression, it's very, very painful to let go of strategies that really haven't worked, and painful to turn towards things that maybe have been put on hold for a long, long time. And so that's part of the work. It's a kind of it's a relatively straightforward thing for me to stand up and explain or say that to you. The work itself is that piece, and so it has to be underpinned by a strong therapeutic alliance and a bold, courageous stance from both client and therapist. So connecting to values, making the work be about values, is part of the work. Okay, so that's kind of the sort of an outline of how ACT looks and how ACT might approach some of the problems with depression. So just briefly, people are often concerned about what is the relationship between ACT and traditional CBT or CT, and the best explanation I've had for that is this sense of they're different parts of the same category. So if we think about categories, that we would have, for example, a category of trees, and within the category of trees we can have pines and oaks, both part of the same thing. And similarly, in terms of ACT and CBT, we have this family of cognitive behavioral therapies, and in that family there is cognitive therapy and there's acceptance and commitment therapy, and we can really see them as being cousins because they actually share grandparents. Behaviorism is their grandparent. We can also add into that, however, sort of other varieties or flavors of ice cream, if you like. That there's mindfulness-based cognitive therapy, overlaps with cognitive therapy, has some overlap with acceptance and commitment therapy, and is one of the family of cognitive behavioral therapies. Similarly, behavioral activation is a therapy that has much less emphasis on this cognitive part and more emphasis on this sort of value, on the goal-setting part. And again, that overlaps with acceptance and commitment therapy, is one of the family of cognitive behavioral therapies. And so when we're trying to think about, well, how is ACT distinct or similar to these different other kinds of cognitive behavioral therapies, I think this slide helps us with that. That at the level of, if we think about ACT at only the level of techniques and interventions, we'll see an awful lot of overlap between what you do in ACT. We're still talking about thoughts, feelings, behaviors. We might use imagery, we might use kind of talk, we might use exercises, mindfulness exercises and so forth. So at the level of techniques and interventions, there's really a huge amount of overlap between ACT and other therapies and not that much distinction. But at some of the concepts and theories, they start to diverge. So for example, in cognitive therapy, the concept and theory is that we are changing thoughts and changing how people believe, and that will lead to changes in emotions and behaviors. In ACT, by contrast, we're not trying to change thoughts, we're trying to change how people relate to thoughts. So the thought itself doesn't need to change, simply how we stand towards it and unhooking thoughts as reasons for doing things or not doing things. And where they really diverge is at this level of philosophical assumption, that the ACT is based upon quite a radically different view of a philosophy of science, that our job is not to kind of try and discover the world out there as if scientists were not part of that equation, but to produce what we think of as being pragmatic, workable answers to human problems. So if people are interested, I put a little bit of further reading here. First of all, from the point of view of kind of getting into ACT as a sort of a self-help piece, regardless of what your background is. Then Russ Harris's The Happiness Trap is a really good place to start. If you are more interested in the scientific aspects of it, regardless of what your background is, then there's a recent edition of Behavior Therapy, a special series that was edited by David Fresco called Theories and Directions in Behavior Therapy, ACT in Contemporary CBT, where different leaders in the field outlined different aspects of it and then had commentary and so forth. So people are interested, there's further reading there. And I hope I have not gone over my time. That's my end.